Hello, and welcome to today's FQHC Connect webinar, a fireside chat, the hidden cost of peer reviews and how leading health centers are rethinking them. I'm your host, Steve Weinman, principal with FQHC Associates. Today, I have the pleasure of being joined by three distinguished guests. First is Misty Schell, Senior Director of Clinical Operations at MedPlace. Next is Michael Ellenby, VP of Business Development also at MedPlace. Last but not least is Israel Mendez, Medical Director at Charlotte Community Health Clinic in beautiful Charlotte, North Carolina. Before we get started, I've got a few housekeeping issues I'd like to go over. First, we are recording this session. The recording will be available in the FQHC Connect community by next week. If you're not already a member and you're affiliated with a community health center, network, or primary care association, you can join us at fqhcconnect.com. We always try to keep our webinars interactive and we'll be answering questions as we go along. If you have a question, please type it in the Q&A window. So now, without further ado, let's get started. I will turn it over to Michael.
Thanks very much, Stephen. And by the way, I think you forgot to introduce the most important person in this webinar, which is yourself. For those who don't know, Steve has been around, I think, longer than all of us put together. He's the founder of FQHC Connect and has been in the FQHC world for more than 40 years. So he's got deep experience and knowledge and real-world practical application in FQHC. As part of that, he led and grew a multi-site FQHC and executive leadership roles, ton of experience working with FQHCs nationwide. And I think that's why all of you are here today, because of Steve's background and experience and knowledge and the respect that you've all given him as he's grown over the years.
Well, thank you for that, Michael.
Well, hey, someone's got to say it and you weren't going to do it, so I thought I'd get there. Again, Misty Schell, and she's a Senior Director of Clinical Operations at MedPlace. Again, a ton of experience in FQHC, mainly in operations role. So this is very much in the core of what she's been doing over the last few years. And she's got 25 years in healthcare operations. She's a LPN and also has got an MBA in HCM. And lastly but not least is, as Steve mentioned, got Israel Mendez. He's got an MS. He's also a PA. And he's the medical director at Charlotte Community Health Clinic for 2 years in directing patient care, as well as that published researcher. So he's, again, got a lot of experience in the FQHC world, but specifically in the area of peer review. Just to briefly introduce MedPlace, I'm the head of business development here at MedPlace. We offer medical peer review as a service to FQHC clinics and critical access hospitals, as well as providers, carriers, etc. But about probably 98% of our focus is FQHCs and critical access. Personally, I'm also on the board of the chair of the board of a very large FQHC based in Arizona, so I understand this world as well, and it's a complex world, as you all know. So enough about me. I just hand it over to Misty, and she can start driving the show.
Thanks, Michael. Thanks for having us here today. We're really excited to just talk through some opportunities with you all about how to take the headache out of peer review and some of the hidden costs that you might not recognize are happening internally. And so we really want to break down those myths. As a former senior operations leader in FQHC, I many times thought, oh, we could just do that internally, thinking it was saving us dollars. And when we sat back and we really looked at our return on our investment, it was costing us. It was costing us our sanity and dollars. So we're hoping that we can really walk you through how to evaluate that internally. And if you decide from that it might be a better option to reach out to us, we would love to talk and see how we can support you to be successful, especially with your HRSA requirements and your FTCA requirements. So we're going to start off today with a poll. We'd really like to have an understanding on how you would describe your organization's current approach to measuring peer review return on investment. So what are you doing internally to really identify, how much work, effort, dollars, time, missing out on possible patient visits that's happening within your organization to support this program. And we love Q&A and comments. So if you have anything you want to share and expand on, we'd love to have that conversation as well. So feel free to enter those. Some of the things to be thinking about here also really include, the administrative time that your supporting teams are giving to these efforts. You know, it's so easy to just think peer review, clinical time, physician time, provider time. But usually there's several other departments and people supporting this. So, you know, really recognizing, do we have a pulse on that? Do we know who all has their hands wrapped up in peer review? That can be your credentialing team, sometimes HR, usually operations, um, other supporting people that you don't realize are spending. I saw something possibly pop up in the chat, Steve.
Yeah, so David Leader said, I'm old, but new to CHCs. Well, yeah, I feel your pain, David. Um, I'm not finding the peer review program we have to be time consuming at all. We do this quarterly and take care of it when we have a no-show.
Great. Sounds like you've figured out some magic sauce.
Yeah, there's also the question of how much peer review you're doing, and we've talked about that amongst ourselves before. There's the amount that you're required to do, and then there's the amount that maybe you really need to be doing. I'm sure that'll get addressed later on. Okay, well, I think we've got our poll complete, so I'm going to end it. So 62% said we don't regularly measure ROI. 8% said we measure ROI and it's been insightful, and 29% said we'd like to measure ROI, but we don't have the right tools. So that's interesting that only 8, but not unexpected, that only 8% of everybody actually has measured the ROI. So I'm glad that we're going to be addressing that today. So I'm going to go ahead and end the poll.
Yeah, our goal today is that you leave with some tools that you can use to really give insight to that for you. So, Steve, I see David asked, how much peer review should we do? And I think we all have a lot of thoughts there. You know, the requirement with HRSA is quarterly. Best practice is 5 charts each quarter. However, we always like to think, are you getting enough data? Do you have tools in place when your peer review trends are showing a concern? And how are you following up and doing additional peer review when needed? Steve, you might have some great insight there. I know that we've spoken a lot about this, about making sure that you're doing peer review enough to stay on top of actionable items, because HRSA does look at that as well, and so does FTCA. So they want to see that you're catching trends, you're being proactive in redirection and
Well,
education.
I mean, I think that peer review has really been looked upon for a long time as a requirement that's put on us. I mean, and again, since I've been doing this for a long time, along with FTCA um, came the requirement that we do peer review. And the guideline has been that we do it quarterly, which is fine, but basically we're looking at maybe one record per provider a month. So that's 12 records a year from, let's say, a provider that's seeing, I don't know, between 3 and 4,000 visits a year. So that's not really a representative sample. Um, so there are definitely ways to determine whether you need to do more peer review or not, and a lot of it would depend on the results of the peer review that you do. And occasionally, when I was at the health center for about 30 years, we had some bad outcomes. And when we had a bad outcome, we would naturally go back and look at the peer review. And you see that we had providers that did something they shouldn't have done, but when we looked at their peer review, it was perfect. Um, and it was the same issue that we had with employees. So you have an employee, they're doing a terrible job. You look at their evaluation and they're a 5-star perfect employee. So it's like, well, how did we miss that? And, I think we're going to go over all the reasons why it's very hard to do, honest and effective peer review internally of people that you have to work with every day. And
Absolutely.
Yep. So let's see. Anonymous attendee wanted to know, should we do quarterly per line of service like dental, OB, behavioral health, medical? Um,
Yes. Absolutely. And this is in HRSA in the chapter 10. There's more explanation there. So definitely get with your HRSA team or whomever's keeping pulse on what HRSA regulations are, make
So,
sure you're
so
connecting.
Lisa has asked where can you cite where quarterly is noted?
Yes, it can be found in HRSA Chapter 10.
Okay.
Team, I know that we are still in the polling, and I want to speak to this a lot more. And I know time is of essence, but I'm looking at the chat where it says we do this quarterly and take care of it when we have a no-show. I want to do speak to that, both as a provider and then as the medical director. I dabble in both worlds, the administrative side, but then the patient care. I want to speak to just burnout to the provider team. I will say when that was put on us in the middle of patient care, hey, do it during a no-show, there really was a lot of dissatisfaction. And not only that, kind of multitasking in between those things can be really complicated because when I put my patient care cap on, I tell the team, the administrative side, hey guys, I'm in patient care. If it's urgent, please come find me. If it's emergency, of course, come pull me. But outside of that, I want to have my patient care cap on and really be focusing on those chats, paperwork, refill requests. So I do want to encourage everybody that's on this call that's administrative to really keep that in mind because asking that of your providers, of course, they're going to go the extra mile. And I'm sure you guys all have those providers who are overachievers, but the other thing too is we all want to tackle the no-show rate. And if you're strategic looking at the no-show rate, is this an opportunity to double book to get more patients in to improve patient outcomes? Would probably be the best approach because again, we have that patient care cap on. So sorry to jump the gun. I know we're still on the poll, but I want to touch on
No,
that.
I guess the poll, I think we're done with the poll. So not to beat a dead horse, but at Israel's point, for one, I'm not a provider, but I find that any work that I do in between doing other things doesn't get the attention that I
Mhm.
want. So it's a matter of if I'm anything I'm doing, and then afterwards I look at what I did, and it's like, wow, that wasn't great because I was trying to multitask and um, it's hard to do. So I think Israel makes a great point that whether you do peer review internally or externally, I think it's important enough to get the full attention of whoever's doing it.
Absolutely. And I really loved your call out, Israel, of really the strategy on how to use those no shows towards patient visits. So that was always on my mind as operations leader. How do I make sure I have patients in slots in the rooms being seen, getting care? And so, um, I think really looking at the administrative tasks that we put on our providers, how can we relieve some of that so they can do what they love, right? Which is patient care and taking care of their patient population. So we're going to go through and start just talking about some myths and reality about return on investment with peer review. And this really can be applied beyond peer review. Our hope is these tools can help you start to think differently and strategically in your clinics and how you can really vet out your needs and where you can strategize a little more clearly. So, peer review myth number one, we don't need to perform an ROI on our existing peer review process. It's included as part of provider admin time. So, Israel, we kind of already spoken about that, but really, whether you're trying to squeeze that in a patient workday or after hours or allotting them admin time, that's time removed from patient care. Is there anything that you would like to expand on that as a provider that you think is really important for operational and quality leaders to understand?
Yeah, I think specifically when it comes to admin time, it's so easy to lump everything into the admin time. But I will say my admin time is still goes back to patient care with those refills, paperwork, phone
Mhm.
calls, lab reviews. I'll tell you this, admin time for the health centers that still do it internally, we're also looping in those peer reviews on top of we whether that's Relias or some sort of other compliance platform that you guys use, for example, for bloodborne pathogen trainings, policy reviews. I know that's also something that health centers do. And then on top of that, too, any billing updates or changes that need to happen, that's all also included into admin time. But if you're on here and have a team of providers where you're lumping all of that, I really do want to advocate for the providers that that time we want to reserve it for patient care, and high quality patient care at that, because it all comes to satisfaction. If you have a patient who sent a MyChart message and the provider has to do XYZ before they can get to that, sometimes that can be a delay in care and affect satisfaction as well. So team, really making sure that we focus the administrative time as much as possible to that patient, because we are all, at the end of the day, patient-centered.
Yeah, 100%. Yeah, definitely something when you're thinking about the cost of peer review to think about internally. Peer review ROI myth number 2, we know how to build an effective ROI model. There's so many things to think about when you're building your return on investment for peer review. And so, not that some don't get it right, but the more and more that we're working with FQHCs, we're finding out that they're missing those hidden costs and that hidden time that it's taking to get these done and to do it well. In HRSA Chapter 10, it talks about actionable next steps. And, if your peer reviews are consistently just coming back with the same information, or it's highlighting concerns and those aren't being addressed, those are things that have to be thought about as well. And that's why an unbiased peer review process is really important. Myth number 3, the spreadsheet we made 4 years ago is good enough. I don't know that we have to really spend a lot of time on this one. We all know healthcare is changing constantly. And so I'm sure my experience was my health center from one year to the next always looked very different as we were changing, as we were getting different legislation. And I'm sure no health center 4 years ago looks the same as it does today. So let's talk the truth. Peer review is HRSA mandated, as we've talked about. It is very high risk if it's not done. We have clients all the time reaching out to us last minute that had a finding on their OSV, or they've had someone actually take the time to really deep dive into what needs to be done for their OSV, and they're calling us saying, help us. We haven't been doing peer review effectively or at all, and we need you to come in and help us. And sometimes we're even doing back reviews for them. So we want to help you not to have that stress on you or your team. So, definitely be thinking about, do I understand what HRSA and even FTCA are wanting to see whenever we are doing these peer review programs? Cost allocation is complex. You have to think about, if you're giving admin time, providers are being taken out of clinical care. Sometimes they're doing these at home at night when they'd rather be with their family or sleeping. And so you start to have provider satisfaction affected, which in turn, leads to turnover. I know in my years at FQHC operations, we always were really trying to balance provider satisfaction, because turnover is so hard on our patient populations. And it really also just affects overall quality and reputation of your health center. Really need to consider all the direct costs, soft costs, and your opportunity costs. Could we be seeing patients during that time we're giving for peer review? How many people are running around chasing down providers trying to get their peer reviews back? I know I had several senior directors, assistant directors, all over 9 clinics. And usually they were chasing people down for me, because at one time we were doing our peer reviews via brown envelope. And that was only a few years ago. And so I had people wasting time that were costing us a lot of money for that wasted time. So that admin overhead cost is real, and it can be often very high. Proficiency of the reviewers. I mean, something that, could take about an hour can take hours, because they're having to do it in blocks. They're trying to fit it in, and then they have to go back and re-review because something else has taken their attention. And bias or not true next steps being able to be determined, especially if people don't feel like they have the freedom to give that constructive criticism to their peer. And also just being able to track what is happening whenever there is a concern. So having a vendor that's able to really give you data that is scoring these forms, showing you, highlighting areas or concerns about behavior or standard of care that you can address quickly, rather than letting an issue continue to fester and grow. Israel, I don't know if you have any other thoughts there.
Yeah, I have several thoughts. I could spend an hour on each one of these points, but for the purpose of time, and I know a few people joined late, but again, I'm at a health center in Charlotte, North Carolina. I am not an employee of MedPlace. They're not paying me to be here. I want to speak to how satisfied we are with their services because at the end of the day, we can look at all these points, but I want to speak to just provider satisfaction and making them feel valued. When we said, listen, this is internal, but here's a partner we're going to work with who's going to be doing the peer reviews, it was just like, wow, thank you for seeing me. Thank you for valuing my time. So if you're in a position and maybe morale is low or turnover is high, and you're thinking of what's the next thing, what else can we do to help the provider team? I feel like this can be really, really beneficial, and I think it would be worth the investment. The other thing too is these peer reviews can be practice changing. And ultimately, that's what we want. If there's a review or something or an audit being done, but it doesn't lead to good change or to better patient outcomes, then is the current workflow working well? And I know there are other slides that will speak to this, so I don't want to jump too soon. But I wrote down a note to specifically put that these peer reviewers with MedPlace, they're doing this 24/7. They're the experts in this field. And we know that medicine is ever changing. So for context, when these peer reviews are being done, and when they're done, I review all of them too, not just my own. But they are citing, things like the task force, the American Academy of Pediatrics, ACOG. So it's all evidence-based as well. And that's all I'll say for this slide. But very, very well received from our group of providers. And if you guys, have questions specifically for me, feel free to use the chat, but I know we can move forward with this.
Thank you, Israel. So we've touched on some of these already. What are some things that you should be asking about your internal peer review process to really understand your capacity, how much work it's taking, the return on investment, areas of improvement, really understanding, are you using your peer reviews to decide next steps for your providers or departments? We have a lot of our clients that, like you said, Israel, this process has been organization changing for them, and they're taking what they're getting on feedback and they're starting quality initiatives, they're starting training work groups, and really finding ways that they can support their provider teams more effectively. They're looking at how they can also support their provider annual review processes using the feedback that they're getting from reviews. You definitely should be asking, does this peer review play a role in addressing your provider behavior concerns? Being proactive, supporting, those are hard conversations to have. And whenever you can bring some unbiased feedback with you to say, hey, we have a concern, we're seeing something consistent that we need to talk about, and we need to decide how to get back on track. That's highly valuable for clinical leaders, especially to start those important conversations. Do your peer review questions align with your internal goals? And so I have found in my own personal experience that often what was happening in my quality and compliance teams was rarely getting over to my peer review side, which lived in our credentialing department at the time. And the questions were not making sense for us. And so when we finally aligned those and said, hey, we really need to see if we can support our quality team on some of their initiatives with the questions that are being asked in peer review, it brings so much collaboration between those teams, and in the end brings a lot of value to the provider teams as well. A lot of our clients are using their peer reviews to start PDSAs, look at their payer incentive goals, and really using it as a way to bring teams together so it doesn't feel so fractured. And then, is your peer review supporting accreditation? Are you able to utilize it with your UDS needs. FTCA, HRSA, we have a lot of our health centers that are trying to become primary care medical homes. And so they're able to use these peer reviews to really meet those accreditation standards.
And Misty, I want to speak to, when I attend things like this, sometimes a good example goes a long way. So something that we caught on after the med place was doing the peer reviews was we were not doing the best job with vaccines, documenting, counseling, and that was just a common pattern we saw. So we brought that to the provider team at our provider meeting, and we're like, hey, team, look. And the provider was like, yep, that's just something that we maybe weren't prioritizing, didn't have time for. But now after this, that's something real that we were able to change. And now there's better counseling, better documentation of it, because some of the providers were like, well, I'm doing it, but if it wasn't documented, we all know the saying. But that's something that I want to speak to. I'm not sure who all's on the call, and I know later on we'll probably use the chat feature to see who's on here. But if you're with quality and with HRSA specifically, you all know about the badges, and this is a real opportunity to work towards that and capture more badges. I know there are emails that go nationwide of these health centers achieving these badges, and we're like, wait, how can we be on that list, and how can we be getting kudos? So this was a way too that we implemented the peer review process with MedPlace to help us achieve those badges.
Yeah, and I want to kind of segue off of that because I had a really cool experience talking about just getting excited about how well you're doing. We at MedPlace we have forms that can be scored, and so I recently ran and I got to go visit one of our health centers, and came across one of our providers that was being reviewed, and she was like, I just got 100% on my review. And so their teams kept saying like it's become really fun for them and actually boosts them, when they see they're doing well, or it creates that creative conversation of, hey, let's look at how to make some changes. And so it gives you something to work towards, which is wonderful.
And there's a question in the chat, what badges specifically did this help you obtain? That was the point. We were on that list, and that's what we're working towards now. And our quality team has a spreadsheet of each of the badges we're specifically trying to achieve. And then one right now, I believe, is there's one about related to behavioral health and depression. And then, of course, one related to vaccines. We're not there yet, but collaboratively, we're trying to achieve that.
Yeah, one thing about HRSA is, I mean, it's great that they came up with the badges, but they're not awfully helpful at telling you how to achieve the badges. I mean, they tell you, what the standard is, but they really haven't told you how. Cookbook
Mhm.
wise. And this really helps with that to see where you
Mhm.
are, how far you have to go. And,
Yeah,
healthy competition is good.
it is. And just being able to trend, being able to see like, gosh, is our current internal process or program for peer review really bringing to the surface things that we could be focusing on strategically? And that I don't know if you can put a dollar amount on that. That's a huge gift, and to be able to say, hey, we can quickly see trends that are happening in the care of our patients and start working towards those to either correct them or be a little more proactive about them. So ROI, how can you really ensure that you have all of the data that you need to do an analysis on your internal program? And if that spurs you to really look outside and see if someone externally, like MedPlace, can come in and really help bring you more value to your program, this is a great exercise to do. And we do this with our clients when we meet with them one-on-one as well. But you would definitely need to have a full understanding. How many providers do you have? What are the provider types that are being reviewed? Are you reviewing all of the people that you need to be reviewing? So making sure that you aren't leaving anyone out, and that anyone that is that primary provider type role or the provider role clinically is being reviewed. Do you have enough providers in your practice to review each other? A lot of our clients will come to us and say, we only have one ophthalmologist. We don't have anyone else to review them. We're really struggling locally to find someone. We have them, and so we're able to support that. So you really get in a bind when you don't have a license available on your team as well. You're having to look outside to find the right people to do those reviews most effectively. How often do you need to perform peer reviews? Again, we're discussing quarterly. How many charts will be pulled for each provider? Right now, there's not really a definitive amount that you have to pull. At MedPlace, we normally say, we recommend 5 to 6 as a best practice. I know Steve shared, is that enough? And so we do have some clients that really look at how they could do that differently, or they have a program where they do the quarterly, but maybe for new providers, they do a 30, 60, and 90-day review to get some extra reviews in as they're learning and onboarding. So there's a lot of ways that you can look at what makes most sense to get you what you need. Do you know your reimbursement rates? That's really important if you're going to do an ROI. Most of the time, you just average those out. You could do it department by department if you wanted to get more specific as well. How long does it take for your peer reviews to be completed internally? We normally say it probably takes most people an hour or more. Some of our clients are reporting sometimes 3 hours. I think that's definitely variable, but typically an hour. How many visits per hour are lost during that time? So, are you giving that provider an administrative time to do their peer review? If so, you're losing visits during that hour that they could be seeing patients. And we know that Israel would agree that's what our providers want to be doing. Do you give your providers time off the floor to perform these reviews? Kind of coincides with that. But also if they're taking these home and doing them at home at night, trying to fit them in before work, trying to squeeze them in during the clinical day, that's a satisfaction consideration. Anything there, Israel, that you think is important to think about?
I agree. You highlighted everything well.
Thank you.
And I have to say, in all the years that I've done this, I've I've never really had a provider say, I really enjoy doing this peer review. I mean, I
Yeah.
suppose out there somewhere there's a sadomasochistic provider that, both feels the joy of finding fault with his fellow providers, but for the most case, this is a dreaded duty. I mean, it's sort of
Mhm.
like filling out your taxes. Everybody, it's got to be done, but nobody really likes doing it.
Yeah. Well, and I always find it, interesting, and I've experienced this firsthand too. No one wants to ever be critical of their fellow provider sitting in their pod with them, right? So they're always going to edge on the side of not giving maybe constructive criticism. Yep, everything looks great, or if they don't, we just had a client reach out that was sharing a past experience of before they went external with their peer review. Someone figured out who had done their review, and the person was not very constructive, gave a lot of criticism, and it caused a lot of tension internally with their team. So I think those are other things to be thinking about on if your program is being successful. Are you getting true unbiased feedback that's helpful? Are you causing unnecessary tensions internally doing these within your internal group?
Well, and the other thing I have found is that the peer review is inconsistent depending on which provider is doing it, because this is not what they do every day.
Mhm.
So, I mean, literally, you could have two providers review the same exact chart. One of them says it's great, and the other one says not so much.
Yeah.
And the other part that I've encountered. So let's suppose you've got a number of dentists. I mean, we had this happen at our health center. Well, the dentists were doing each other's charts. However, some of them were boarded pediatric dentists, and they had a non-pediatric dentist doing their review. And honestly, this person's skill set was not up to snuff to review this other person's chart. So I would argue that they're not truly a peer. And that question came up earlier in the
Yeah.
Q&A as well. I said, how do you define peer? Well, a peer is somebody who does something similar enough to what you do that they're in a position to criticize it. So when it comes to looking at charts, I am nobody's peer because I have not been
Right.
trained to do that. It doesn't mean that they have to work for the same entity.
Yeah, and I'm
Correct.
glad you said that because I was going to speak to that too. And you have providers at different levels of training as well. And medicine is changing. I want to say every day, but I'm going to say every minute. With AI and all these things, we are just medicine is evolving rapidly, and we want everybody to stay up to date. And of course, that expectation for providers varies. You have some very high achieving providers who stay up to date. They're listening to the podcast every day while they work out, and they enjoy doing a peer review. I have one like that. But then there are others who are like, I don't have time for this. Um, and two, like for example, just recently the new cholesterol guidelines and recommendations and changes there regarding LPA screening. Like that's just something that you just have to know. And if you're not in the know, you could be missing out. So again, I just wanted to highlight to what Steve was saying in terms of, each clinician internally could just be doing the peer reviews completely differently versus having something like MedPlace where it's standardized and a better approach. And I know in the chat there was an ask to see a template, and that is part of this presentation as well.
So other considerations on how to calculate this, and we will show you, we actually have a free tool on our website that lets you do your own ROI. So how we kind of base those numbers, for example, is it's about 20 minutes per chart review. If you were losing about 2.5 visits for that hour, there's about $550 per hour of loss of revenue. You will do an average salary cost that we have hard coded in for your provider, MD, DO, dentist level. We kind of put that about 150 on average, depending on how many NPs, PAs, dental hygiene, LCSWs, that will change some of that average as well. And then it's really important to think about your other overhead costs. If you have directors, executive directors, anyone in your credentialing, compliance, HR that are involved in peer review, that's time that you're paying for them to be focused on the peer review rather than probably some of the other things that they need to focus on. And I know from my personal experience, that time was mainly me hunting down people and trying to get the peer review back or reminding them to do the peer review or following up on a concern about it. So it was unnecessary time that I was spending trying to manage our internal program.
Well, depending on your position in the health center, the wasted time might not be visible to you. I mean, for
Right.
example, so when I was in a position of running the health center, so the chief medical officer reported to me, everybody reported to me, and I don't think the people that were doing the peer review, including the CMO, realized the number of times that providers came to my office, sat down, and complained about the peer review that was done. Now, that was the purpose they came in my office, to complain about the peer review. But as long as they were there, they also complained about the number of medical assistants they had and everything else. And I would literally lose an hour each time this would happen. Now, it doesn't sound like much, but when you go over the course of the year, I would say that I wasted just over this one issue 2 days of the year. So it's well, 2 days, you're still working a couple hundred days. Yeah, but I lose 2 days here and 2 days there. And I was having to take everything home and do it because of this lost time. I really didn't appreciate it. Had there been a med place when I was doing this, I would have so gladly handed it off because then my answer would have been, you know what? We hire some professionals to do it. You and the CMO, you go talk to them. Have a nice day. And so I'm just looking at it from the CEO's point of view. It completely eliminates the he said, she said dynamic internally, and that is extremely valuable.
Yeah,
Um,
100%.
some somebody asked whether you do peer review on medical assistants and dental assistants.
We do not. We do not have many requests with the guidelines. We do dental hygiene. We have not had any requests for RN, and I don't believe they fall under that purview with HRSA. But personally, as someone who's been in clinical leadership for several years, I would love to see that be something that happens in the future. I think there's a lot of value there. And I think in turn could become a provider satisfaction because I, as well in some of my leadership roles, had providers in my office complaining about their medical assistants. not just the number, but how they were trained, how they were performing. And so I think it's definitely worth exploring. It's not currently something that's required.
And I'm not sure it would be necessarily be a peer that would
Mhm.
review them. I mean, because
Right,
this is really for
right.
licensed independent
Yeah.
practitioners. So hopefully the medical assistants are being monitored by the providers that they work for, as well as the manager, whoever is managing, according to your structure, whether it's a nursing director or a clinic director or whoever.
Yeah, absolutely. So we've already touched on some of these. The benefits of external review, we're seeing 10 to 50% savings by the time our clients are walking through the ROI. Unbiased reviews, getting that true picture of what's happening. Automated reviews, you are not chasing people around. Everything's done on our platform. They're there for you. They're organized and ready to go. Rich data that can feed into your quality programs, identifying behaviors early and often, being able to shift to more proactive approaches, avoiding provider burnout. Israel, I know that you spoke into that a lot. Just, you know, even just trying to fit that in throughout your clinical day, taking it home, doing it before you come into clinic, it really starts to wear on your provider teams along with everything else they have to do. So I wanted to take a minute. It looks like we have some time and just show you. We will make sure that you have access to this. Our ROI calculator that you can use freely to really see, some of the hidden areas that you may be missing. So when you go in here, you will enter in your MD level provider. So that's however many dentists, MDs, DOs, that you have psychiatrists, and you can plug that number in here. Your advanced practice clinicians, in that number, I would include your NPs, PAs, dental hygiene, LCSWs, optometrists, and we'll just put in a fake number here. And then your review frequency. Again, we know the requirement is quarterly, but you are able to select what sort of ROI you want to produce here. We do work with clients that are not under the HRSA guidelines. And then how many charts per period? Like we said, 5 to 6 is best practice. Definitely want to consider what you need as an internal team. And then you're able to run this ROI calculator to show how much you could be saving by doing this externally. We would love to speak with you. If you want to have a further conversation, we can give you a customized number and walk through that with you. But this does give you a quick glimpse on what you could be missing out on. Here it also talks about like time per chart to complete the reviews. That would be important to know about how many visits per hour you could be losing of patient care, and then your average hourly salaries that are being spent on that as well. So we encourage you definitely get in there and play with the calculator and see if you're able to see where you could be exposing some costs that you're not aware of. I also wanted to point out here that we do offer a free form generator on our website. So maybe you think, hey, I think we have this under control. I'd really like to just have a more structured form. We want to give you the tools to be able to do that so that you can be successful in your accreditations and in your requirements. So we have a form generator. You can go in and plug in some information and it'll give you a beautiful form that can be scored for your teams. All right. Well, I think that we really covered everything. Israel, is there anything else that you think would be important to share?
Yeah, I guess previously to just some wins. Our completion rate per quarter sometimes varied, 80%, 90%, but now it's consistently 100%, So I also wanted to highlight that. And then I'm not sure, is there a screenshot of the actual template again?
There is one. Let me show. just briefly, I can touch on this. This is kind of how the process works with MedPlace. So you would load encounters. We also have chart pooling program where I have a team of clinical staff that go into EHRs and build out everything for you. So that's additional time savings for your team. You select your expert. You get to see CVs, look at their background. We do the analysis, and then you download your report. I have a little bit more close up of the report here. So you have everything, all your questions. We work with you to align those. You can have scoring. And then we also have the ability to data trend. So we can begin showing you collative data. We can show you provider by provider. We can show you department, compare your departments to each other, compare your providers to each other. So this is something that we're rolling out very soon and are very excited to have as an option for our clients. There we
Yeah,
go.
and those reports, they really impress the people that get to see them, particularly the board members, because again, they're not a lot of them are not medical professionals and but they do have to have confidence that what you're providing is good care. And it really helps to show them that you've got this sophisticated system. So the other thing is, and I guess, being old, as was pointed out earlier, the years that I did this, if you're keeping your peer review data internally, it's very important for you to know where it is at all times. So we had a case where a director of quality departed suddenly. And when she departed, so did her files, including all of our peer review records for the current period and the previous periods. So we were in a position, I mean, this person just disappeared. We couldn't get hold of them anymore. They were gone. It was not on our network. It was not anywhere we could get it. And we literally, as Ricky Ricardo used to say, we had a lot of splaining to do. So
Yeah.
what I consider to be a huge advantage of this is the fact that they have a database that is stored safely. You don't have to worry about it being lost. And it's also stored in a well thought out professional manner, not in a spreadsheet that somebody slapped together in their spare time. I mean, so that is huge because if these records are gone, you have a problem.
And then two, for this is also, of course, what the provider gets once everything's completed. And then to address the question in the Q&A is who would select assessment topics? You customize these. Of course, MedPlace has the standard template, but you can tweak and change it. For example, our pediatricians have one that's slightly different. Versus, maybe the chief dental officer would collaborate and work with MedPlace to customize the one for the dentist and etc. But yeah, this has been something that we've been able to tweak and adjust. And then this is to how we kind of help align with the badges. For example, there's one specifically about diabetes that we can use too.
Yeah, we've been seeing that a lot, especially like for payer incentives. We have a lot of people that are doing that with elevated blood pressures, trying to really trend out what they're seeing on improvement because they're doing a lot of PDSA and training to capture those payer incentive dollars. And so we're able to really customize that for what you're working on.
Well, great. I mean, that was extremely informative presentation. So what I'm going to do at this point is I'm going to put another poll out there. This is our webinar contact poll, and you will let us know, what follow-up action, if any, you would like to see. So I'm going to launch that right now.
I have some people asking if we can zoom in and things. We're going to make sure that you get access to some of this, so you'll be able to see it as well.
Yeah, a trick I learned with Zoom is that you can actually zoom in on the viewer's side if you
Yes.
want. So
Yes.
again, um, addressing my advanced age, my eyesight is not what it used to be. In fact, I have cataract surgery in 2 weeks. So
Oh,
that is a very handy feature for these tired
yes.
old eyes.
Man, you're going to probably feel like a new person.
I hope so.
I do want to call out on this last slide. If you are interested in booking a demo, doing customized pricing for your organization, please reach out to Mason. And either she and I often get on calls together, and we'd love to chat with you. And then I have to call out Megan. I don't know if she's still on here. Megan is from my health center in Colorado. So it's so good to see somebody on here that I got the joy of working with at an FQHC.
And then I'll say this, and probably this will be the last thing, but I really do enjoy MedPlace. And again, I'm not affiliated anyway, but I think I want to highlight and value Mason. She's the secret sauce. She is the partner solutions who I work closely with, and she's always very responsive, very approachable, very kind. And in this stressful times in healthcare for everybody, it's always refreshing to be able to work with someone who's very responsive. So if you reach out directly to this email, Mason, you'll get somebody who's a real human and who will be very responsive. So thank you all, and I hope you found this to be very helpful. Again, I'm just somebody who is at a different FQHC who uses this service, and our team and organization has benefited tremendously. So thank you guys for your time.
Thank you, everyone.
Thank you, everybody. Thank you, Misty. Thank you, Israel. Thank you, Steve. Really appreciate your time and a really informative presentation. At the end, if you'd like to reach out for more information, there's the poll that Steve just also put up, but also directly email mason.mcgarren@medplace.com, and we'd be more than happy to have a conversation and see how we can potentially help you through this. Thank you very much, and that's it.